Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is brought to you by High Tech Answers and Healthcare Now Radio, part of the Answers Media Network, and is sponsored by the law offices of Myrick O'Connell. Now here is your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Anne Marie Polak, Senior Director at Leavitt Partners. Welcome, Anne Marie.
Hi, thank you.
Well, it's great to have you on today. Before we kind of dive into our main topic of conversation, could you just give everyone a little bit of an introduction as to who you are and what you do?
Yeah, absolutely. My name is Anne Marie Polak, and I am a Senior Director here at Leavitt Partners. Our firm is headquartered in Salt Lake City and was founded by Governor Mike Leavitt. He was also the former Secretary of HHS under George W. Bush, and so healthcare has always been a passion of his. And we have taken up the gauntlet there here in our Washington, D.C. office, doing a lot of work moving the healthcare system, transitioning to value-based payments and really trying to drive value forward in the healthcare system.
So have you always been involved in the healthcare space, or is this a newer passion for you?
I have. For the last number of years, I've worked specifically on healthcare with a lot of emphasis on payment and reimbursement. Here, the fun opportunity through Leavitt Partners is really our ability to convene alliances. And that part is new and specific to the firm, bringing together stakeholders from across the country with diversity of interests in a particular area and really having them meet at the table and talk about potential solutions. And then, as we've done here, really driving to a consensus document that hopefully will be piloted by a number of entities across the country and gain some traction.
What will be our main topic of conversation, and just to kind of give it the preview, will be focusing on an addiction treatment alternative payment model that it sounds like you were definitely involved in, and tying that into value-based care. So would you like to give an overview of what that addiction-focused treatment model entails?
Sure, I would be happy to. So the origin of this was really Leavitt Partners and Facing Addiction, which is a patient advocacy group focused on facing addiction. We came together and wanted to come up with an alternative way to ensure people who are suffering from addiction are not only able to recover, but able to maintain that recovery once they are back in the community. And so part of that, a key part of that, is coming up with an alternative payment model that spans the acute care that's more intensive outpatient or residential, but then also incorporates the activities that individuals try to engage with in the community when they are in the early stages of recovery. And so our view was tying all of that together is really important and something that's lacking in the current healthcare system today.
So kind of thinking, as you just said, that the model that you've developed is to help cover what's lacking in the current system. Maybe it would be helpful to dive into how the current system is set up with regard to addiction treatment. Sure.
Well, the current addiction health services, behavioral health, is probably a good way to refer to it as a bit fragmented in the sense that it is mostly fee-for-service. So the incentives there are to treat the individual and then to pass them on to the next provider without sort of a warm handoff, without that level of care coordination that people on this recovery journey can really benefit from. So in that sense, it's not set up with the incentives to tie all of it together. And then similarly, there are many states that carve, especially for the Medicaid program, carve out behavioral health from the separate payments for physical health. And so what we have seen there is certain states have certain requirements in terms of how the funding flows. And as a result, there's really just a very state-by-state method of how people can best access treatment.
And to some degree, it almost seems like that's a little bit of a microcosm for the state of the healthcare industry as a whole, in terms of talking about, an unfortunate lack of incentive for care coordination, which would seem to be the underpinning of the fee for service system that we are hopefully moving away from.
Yeah, I think that's very true. I think there have been some attempts to coordinate that better by paying for the service, assigning a code to it and then making sure that physicians are communicating. But I think there's a number of elements that are still very challenging in executing that today. One of them actually that we'll get into in a bit more detail as I describe the model here is the prohibitions on sharing the medical record, and particularly those that have to do with behavioral health and addiction treatment. It's actually extremely difficult to have that medical record shared among providers. And without that, care coordination is fairly challenging.
Yes, let's try to unpack that a little bit. Although maybe I'll just pose a question to you first, based on what you just said. Would you rather start talking about the actual model itself first, or get into that medical record sharing issue, which is, obviously ties into privacy concerns?
Right. Well, why don't I describe the elements of the model, and that one features prominently into one of them, and so I'm happy to dive in when I get to that there.
All right, that'll be perfect.
Good. So what we came up with is a model that has adopted a payment system that is a bit of a hybrid of capitated payment and bundled payment. And I can explain that more in detail in a moment. But it is a payment system that is pegged to quality metrics, and we have worked closely with NCQA as they are developing quality metrics specifically for this space. It applies to a network of providers, and we envision that network of providers to be integrated delivery networks or almost an ACO-like combination of providers with shared patient attribution. So I think, that one of the limitations on the integrated delivery systems is there are only a handful of them that are across the country. And so we wanted to make it broader and make sure there's applicability to many different geographies. And so this concept of providers coming together with a risk-bearing entity, working with a payer, making sure that care can be provided that way. So that's the network. One of the key components of this network, as I was mentioning earlier, is this ability to share the medical records and the treatment plan across all of the participating providers. And the patient really needs to consent right up front to that. In order for the patient to enter into this treatment program, we have established that they need to both consent to some element of clinical treatment and also to consent to share the medical record among participating providers. So that's the network requirement. There's also a care recovery team, and the issue of import there is really that there is this peer recovery coach, so somebody to walk you through the process and be there when you need support, and a combination of addiction specialists. And we'd love to create more integration with primary care and individuals who will kind of help you through each step of the process. So there's this care recovery team, and of course we view the patient and the patient's family where it's relevant as really key and integral parts to that too. And then the treatment and recovery plan that we took, it is a modification of the Favor Greenville in South Carolina plan. And the idea is really with a lot of emphasis on reentry into the community and ways to stay engaged and to keep the recovery journey moving forward and to avoid recovery disruption. So if it makes sense, so those are the elements of it. And I might dive more into the payment model if that's something that's interesting.
No, I think so. But before we get to that point, I kind of wanted to, expand on that network and the care delivery team a little bit more. Would you be finding it that would be a collection of equals, or would one kind of aspect of that continuum be taking the lead?
Well, there is definitely a lead, just in order to help with the coordination and have that level of accountability. But yes, it's there's a care coordinator who takes that lead. There is a recovery coach. There are the physicians who are actively delivering treatment, behavioral health specialists, addiction medicine doctors, and then anyone who is also participating on the physical and dental care, all of these other, we view them as part of the care team. There's a bit of a distinction in that many of the counselors and social services individuals in the community we've structured it such that there's a core team that's always part of the care coordination. And then as needed for each individual, entities in the community, counselors, physical health providers, dental health providers are able to kind of move in and out of the care team as needed and on an ongoing basis.
The description of that breadth of the care team actually seems to go further than you might hear from the more physical medicine side of things in terms of creating a value-based care team. It's a couple of those types of providers, just thinking like dentists and some more of the mental health providers that you were mentioning. Oftentimes, I feel like oftentimes you don't hear about those in the, as I said, the value-based care model is out, focused just on physical health. So, would you envision that this could potentially be a spur to just have those broader, arguably more complete networks on the whole when you're thinking about any value-based care initiative?
Well, I do think that would be a great step in the right direction. And the way the model is structured, there is payment given to the risk-bearing entity, and then that risk-bearing entity can make decisions about what other providers are going to be necessary and beneficial for the individual in their recovery journey. So it can be entities in the community who aren't traditionally contracted with payers, and this is to us just a great way to bring them into traditional healthcare. In many ways, it sort of touches on another hot topic, the social determinants of care, things like housing and transportation and meetings and support groups, things that are really vital to keeping somebody on the right track, but who aren't traditionally considered through contracting in the healthcare system.
Right. And maybe this is an allusion to kind of what you're hinting at in terms of how the payment model is set up. But, kind of as you said, that you have a risk-bearing entity in the middle that can then establish the network that it wants to around it, since it has the money to spend. It really feels like that's shifting that kind of network creation role that you often see from an insurance company onto whichever entity is filling that risk-bearing lead role. So before maybe thinking about how the payment model breaks down, or maybe this is part of it, who would you ideally envision being in that role of being the center for that risk-bearing proposition?
Well, first I want to say I think that's an excellent point, sort of shifting the in and out of network determinations away from the payer and more towards the actual risk-bearing entity and those who are contracting. I think the idea really is to give the providers, based on the evidence they're seeing in their own communities, recognition for what's working, and for certain individuals, what's a path that's going to be necessary. And so I do think that it's a great way to put it. And hopefully you end up with payers who take this collaborative approach as well, understanding that the better you can treat individuals who are suffering from addiction, that it will help their community as well.
Yeah, and for those of you just joining, I'm talking with Anne Marie Polak from Leavitt Partners about addiction treatment and a new alternative payment model that's being proposed. And just kind of picking up on where we are, I think maybe now it makes sense, as you had suggested before, of explaining in a little bit more detail how you envision the payment model actually functioning.
Yeah, absolutely. So it was such a pleasure to come up with this. It was really talking with some of the most thoughtful and just operational individuals, people who are doing this on a daily basis. And so we convened a work group once a week and talked through just, we started with what are the drawbacks of fee for service and what are some ways we can overcome that with a revised payment model. And it really took shape over the course of the year. And, individuals on there really liked the concept of bundled payments, but they did not necessarily want to prescribe for the providers exactly what activities could fall into that bundle. So they didn't like the restrictive nature of defining exactly what type of activities and a certain time frame for the bundled payment. And so we did away with those two restrictions, and we created two different episodes of care that really served as sort of the two different triggers for payment. The first one is the recovery. Actually, it's important to note that recovery initiation, so when individuals enter an intensive care or an ER for those initial stages, many times it's for detox, those are still paid under fee for service. And it's really episode number one, recovery initiation and active treatment, that begins the process and really starts the model and the payment that corresponds to it. So it's individuals coming in and seeking treatment in residential care or intensive outpatient care. And the important part is that's the bundled element of it. It's for that particular episode. But we've also incorporated elements of capitated payment by tiering the payment towards patient severity. So we envision that the payment for those episodes moves up or down based on the factors that will dictate sort of the overall difficulty level of treating that particular patient. And at the outset, we plan on basing that on previous claims because it's known and will be a good starting point. But I think ultimately the providers who are treating the patient will get a better sense as that patient progresses through the program, whether or not there are other, I love the term recovery capital, but other things that patient can bring that things like stable housing and a family to support them that are indicators of sort of the overall risk for that patient. And so they can go up and down on that scale. So that's the capitated portion, and the bundled payment is the payments per episode. And we envision this first episode really being the high intensity, high clinical care, a lot of the engagement from that traditional care team in traditional healthcare settings. And then at a time when the providers and the patient agree that the movement to the next episode, community-based recovery management, there is a shift in the payment. And so the second episode is less, it's envisioned as less of a payment than the first episode, but it is still adjusted for patient severity. And whereas a patient could come in episode 1 at a high level of severity, perhaps in the course of their treatment they move down, or vice versa. Perhaps they move back up. And so there is room for modification of the payment along the continuum. I think the other element that's really interesting and that we intentionally built into this is, again, there's the payment for the first episode, payment for the second episode, and if there is a recovery disruption that occurs in the second episode, so once this individual is back in the community, they do have a relapse and they're back in treatment, the payment for that, the care that individual receives as they're coming back into higher clinical acuity type care, back in sort of that phase 1 recovery initiation once again, the payment doesn't change back to the episode 1 higher amount. And we did that in order to really incent all of the providers to work together to keep people in that community-based recovery in recovery. And in our minds, if it moved back up to the higher payment in episode 1, that's not terribly different from the fee-for-service incentives. And so in our case, it was really, let's reward excellent care given by the providers, keeping a patient on that recovery journey by structuring the payments this way.
No, that would definitely seem to make sense, because as you said, if you could have an interruption and then the payment would keep bouncing back up to what sounds like a higher level of payment for the first episode, then there would arguably be a perverse incentive to keep having those interruptions, to keep going back to that higher level of reimbursement.
Yeah, that's exactly right. So that's how we structured the first element of the payment model. There's another one that comes in with the quality metrics. And so as I noted, NCQA is coming up with some quality metrics for addiction health services. And providers will agree to the quality metrics at participation in the model. And they are eligible for bonuses from the payer when they do achieve these quality metrics, when their outcomes, it's both outcomes measures, process measures, and some of it is initial entry criteria for providers. And so there is that type of value-based incentive to really deliver excellent care. And then finally, there is an additional shared savings bonus opportunity for the entire system, so providers and payers. And our hope is that with better addiction treatment and this incentive to refer individuals out for, as I mentioned, the dental care, the underlying physical health issues, other separate behavioral health issues, when you have robust referrals and a patient who's really getting care for everything everything going on in their lives, the goal and the belief is that will overall reduce the cost of care for that individual, and that there will be this pool of savings over what the baseline would have been that can be split between the network of providers and the payer. So really 3 different ways within that overall model that providers can benefit by keeping individuals on that recovery track.
The description of all those elements certainly seems to kind of pull from most of the major types of value-based care models that are put out there. So the challenge that you set for yourself in terms of designing a model that incorporates all those different concepts and different elements certainly seems to have upped the challenge considerably.
Well, I think that's a good point. I also think they all serve sort of slightly different roles within the overall model. You do need some way to recognize that there are varying degrees of care acuity and just this, there are different patients that come in. So on some level, having it capitated and adjusted that way it makes a lot of sense for providers. And having quality metrics be part of it is huge, not only for the individuals who kind of have more of a sense of what type of care they are going to receive, but just it also is that backstop to make sure that not only the processes but the outcomes really are doing what they say they are going to do. Again, at the end of the day, if this ends up saving money, but our quality metrics for entities who are piloting this model really fall short, then I think we need to go back to the drawing board, because the goal is to not only reduce costs, but also to keep people in recovery. And if it's consistently showing through the quality metrics that that's not the case, then, we need to revise that.
Right. And kind of just to help get a little bit better picture in terms of, I think you're describing kind of a mix of a bundled and a capitated type payment. Are those retrospective or prospective, or some kind of combination of the two?
So that is a great question. We did discuss that at our meetings, and where folks landed on that is it really could operate both ways, and we left it up to the piloting participants to come up with whether they'd like to see it as retrospective or prospective.
That'll be very interesting. Be able to get a very much real world study to figure out if one system or the other has an impact on the ability for success, or if it really doesn't have an impact.
Mm-hmm. And I think too, we needed the providers to have a comfort level with taking on this risk in order to enter into it. And so, at the moment, providers are a lot more comfortable with the retrospective payment organization, but as time moves on, perhaps the perspective becomes more and more appealing as they've had a chance to see the way this model operates.
Yeah, that will be interesting, because I feel like when I've worked on value-based contracts, or just talked with some of my clients more in the traditional physical health realm, taking on risk where it's more of a capitated model, then easier to be more on a prospective basis, arguably. And I think those providers certainly appreciate having a clear sense of what pot of money you're working with, but kind of having this hybrid model where it's not necessarily the entire patient population, where you have more comfort in terms of knowing who's going to fit into what bucket. Having the ability to be fluid certainly sounds like it makes sense. Unfortunately, as we're already starting to get close to the end of our time, I kind of just like to get your sense of, where do you think a treatment of addiction sits within the overall healthcare system now? And, what steps would you like to hopefully see to have that improved and be able to have, I'd say more comprehensive and more, I want to say fulfilling, but I don't know if that's necessarily the right word, but, just, be able to have better access and better outcomes for this issue?
Well, it really seems like we're at a unique time in this where there's this confluence of not only movement towards value and alternative payment models and the importance of assessing through quality metrics the type of care we're providing, but I also think there is a lot more attention right now, in particular with the opioid epidemic on addiction and the best ways to get those individuals into treatment. And this model applies to alcohol as well. And I think sometimes that gets a bit overshadowed because opioids are in the news so much, but it applies equally to those suffering from alcohol addictions or opioid addictions. And I think a number of folks have really recognized that as this influx of money to help them treat the epidemic comes in, it would be great to have a roadmap for states as to how to structure their healthcare workforces in a way to be able to have robust provider networks and to be able to really stand up a pilot like this. Because again, one of the barriers really for patients seeking treatment is provider capacity. So it's fantastic to be at a time when the transition to value and the attention on addiction is both sort of coming together.
No, I agree. It is a very interesting and arguably fun time to be within healthcare. But as I'd already alluded to, believe it or not, we are out of time. I want to thank my guest Anne Marie Polak for a great conversation today.
Well, thank you so much. It was my pleasure.
Yeah, no, it was great to have you on, and thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.